Welcome to Sex Care is Self-Care, a conversation on women's sexual health brought to you by the She Plus Foundation. I'm your host, Patty Brisben. I'm coming with two very, very special guests and members of the She Plus Foundation Medical Advisory Board, Dr. Sheryl Kingsberg and Dr. Anita Mikkilineni. You both have been guests on the podcast before, but I know that there's listeners out there that might be brand new and listening for the first time. Dr. Kingsberg, can we start with you? What do you do on a daily basis? Who are you?
Well, Patty, first of all, I am a woman. Secondly, I am a clinical psychologist. And so one of the reasons I start with I'm a woman is because we're trying to reach every woman here and talk about what's affecting all of us. So professionally, I am the chief of a division of behavioral medicine at University Hospitals in Cleveland. I'm a professor at Case Western Reserve University School of Medicine. So I have a division of psychologists within an OBGYN department because we think mental health is so important for women's health. As you also may know, I'm a past president of the International Society for the Study of Women's Sexual Health and the Menopause Society. So my focus tends to be on women's sexual function and on midlife women's health. And so clinically, I tend to focus on that, but I also do pregnancy loss, infertility, postpartum depression. So I cover the gamut of all the psychological aspects of women's health. That's what I do professionally. Personally, I try to play golf, not very well.
Oh, we're so glad to have you, and we're proud and honored that you set our board at the She Plus Foundation. So thank you so much for all that you do for women. Anita, do you want to say your last name? Because I seem to screw it up, and I'm so glad that some of your patients call you Dr. Mickey, and that's probably what I'm going to do during the show.
Don't worry, it gets easier the more you practice. But so my name's Anita Mikkilineni, and my pronouns are she, her. And I am faculty at GW Department of OBGYN. I'm a full-time generalist, so I still deliver babies, take call, to take care of women for their annual preventative care. But I also am a sexual health expert and take care of women both with vulvar disorders, genitopelvic pain, pretty much anything in the chronic pain atmosphere when it comes to your vulva and pelvis. I also, because I'm at the Academic Center, George Washington, have the privilege to be faculty for our SAGA Center, the Sexual Health and Gender Affirmation Center. And we have one of two sexual medicine fellowships for OBGYNs that I get to be faculty for, and a new fellow starting this August, which we're really excited about, our second fellow, as well as I'm the resident rotation director for our OBGYN residents in their third year to train in sexual medicine and pain and get some gender exposure too. And it's a mandatory rotation because one of my core tenets and career goals is to institute mandatory training for all OBGYN residents. So anyone going anywhere in the world during their annual can bring up your sexual health and pain concerns and at least know how to do a baseline diagnostic and management treatment plan for you as a woman. So that's kind of my passion. And socially, mother of two kids right now, under 4. I don't have too much of a social life, but it's been really fun watching the little guys grow up and kind of seeing where they're going.
Congratulations. You're a mother of a new baby. How old?
3.5 weeks.
And look how great you look. I'm so glad that you're here.
Thank you. Sealer does a lot of the work for me, but thank you for saying that.
Yeah. Thank you for all that you do for women. And most of all, listening to what you have to say about what you do on a daily basis. I love the fact that you're training your docs. So when they do leave, that they have this training and they will pay it forward as they're doing their training down the road. I think that there's not enough of you to go around. So, and thank you for setting our board. I'm like, I pinch myself that I have these two amazing docs sitting in front of me that help us every day. So thank you.
Hey, what
You,
can I just say to Dr. Mickey? It was so great to get. I met her many years ago now, and I just knew she was amazing. First of all, I tried to get her to come to Cleveland, and she said no. And so I just knew she would be perfect for the board, and she has been amazing. And you'll talk about this later that she's taken over as advocacy chair for ISWISH. And not to be outdone, we have the other fellowship in sexual medicine at University Hospitals Cleveland Medical Center. So we are the only two fellowships, but they had it first.
that's amazing. I mean, you both are pioneers. You are very driven in making sure that people are trained in doing the right thing for women. So, again, I'm proud just to know you. So thank you again for everything that you do. But I can only imagine what these last few months of chaos feel like. What has changed in your practices in the last several months?
Well, first of all, I will tell you that the level of anxiety of my patients has gone way up.
Mhm.
I'm in women's health, and so a lot of my patients are coming in either pregnant and very concerned about, what happens if I have a problem with my pregnancy?
Mhm.
What are my rights? What's going to happen to me? Will I get into trouble? Will somebody take care of me if I'm in trouble? They're very, very worried. So some women are even worried about getting pregnant for fear that something might happen. I also work in the reproductive endocrine program. We have a big fertility program. And so I see a lot of my patients very concerned about whether IVF will still be viable and, what are they going to be able to do? And, what are embryos seen as? So I get a lot of concern there. With my GLBTQ patients, they're very worried about whether their rights to health care will be impacted. So just on a clinical basis, anxiety has gone way up, way up.
I,
Yeah, I'll just mirror. Oh, sorry.
no, I can only imagine.
Yeah, I'll just mirror what Dr. Kingsberg said. Frankly, patients are just scared. Women's health has already been an undervalued and under-researched area.
Mhm.
And clinically, we're seeing patients come in for more replacement IUDs before they expire, surgical sterilization surgeries. A lot of our federal workers who lost jobs or are concerned about losing jobs are running in for annual exams, pap smears, getting every workup they can get because they're not sure if they're going to have job security in the near future, or they've already lost it. So women have lost pregnancy coverage in that arena as well. So it's pretty awful what we're seeing. And it also reflects how uncertain patients are, not just on the availability of these fundamental rights to contraception and abortion access, but that feeling that they need to be prepared for the worst, kind of adds that anxiety that Dr. Kingsberg was mentioning. And the um, I've just never had so many appointments with patients where patients are in literal tears and they don't actually have any medical problem going on, out of fear and anger at the changes that are taking place. It's just been really a dehumanizing experience for patients.
It 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 saddens me. I mean, I had more rights as a young woman than my granddaughters have right now. And if they, either one of them, I mean, they're not ready to start families or anything like that. But if either one of them would come home and say, "Oh, I met the right person, and we're going to start a family," I think I would lose it because if something happened to one
Mhm.
of them, would we lose them? So I can see where patients are really uptight, and I hate watching us take these steps backwards. I hate reading the headlines every single morning or turning on my Good Morning America because it's what are you bringing here today? Are you clinging on to any glimmers of hope right now?
Very Personally, I have hope when I see really strong, powerful institutions, for example, Harvard, standing up for what's right. Organizations like the She Plus Foundation are also really setting an example for this type of strength and bravery that a lot of research, academic, and medical institutions could really learn from. So I'm incredibly appreciative on the leadership with regards to that because unfortunately I'm seeing a paucity of that amongst our medical and academic institutions. I see renewed vigor in women to advocate for themselves and each other. Although my patients are angry and fearful, they're also ready to fight back. Maybe if they didn't agree on everything politically, this is one unifying front that brings me a lot of hope.
Yes, agree.
You want to hear from me? Well, people like Dr. Mickey are what gives me hope. This is the next generation. And to your point about your granddaughters having less rights than you had, it is my hope that, sometimes you have to really kind of reach rock bottom before there is a swell of energy. And I can't imagine going much farther down. So this is the moment, when there were protests across the country just a few weeks ago, that gave me energy and hope to think that, as a group, we can push back, and also individuals that are standing up and not afraid of a bully, to be able to push back, knowing that there might be retribution, but standing up anyway, and including some free press. It's so worrisome to me that everybody is so siloed and social media has changed so much that, people are being fed incorrect news. And so, as much as it's hard to read the headlines from the New York Times, I do it because you need to see what's actually happening.
So here's my next question for the average patient. How is these changes that the administration is making, how's it going to impact their health care? How is it impacting?
So we're already seeing abortion restrictions and difficulty with access to care. We're seeing changes to insurance coverage when it comes to contraception. It's going to be, in some cases, not accessible or too expensive. And this is something the Affordable Care Act had pretty much guaranteed all patients. The legal uncertainty that Dr. Kingsberg alluded to with IVF. We may see a loss of coverage for preventative services if they dial back the Affordable Care Act. That includes your mammogram, your pap smear, prenatal care. And of course, this is going to affect our lower income women primarily, but it could affect more than that. And large cuts to maternal health programs that we're already seeing can affect postpartum coverage expansions, particularly rural and low income women. This was a big move, especially by the American College of OBGYNs, to improve access postpartum to not just the 6 weeks after you have a baby, but up to a year, to make sure people didn't have a loss in coverage. And that was a huge gain for women's health. Telehealth changes was a huge advancement that we've already lost almost completely, with exception of some mental health services. And that was huge for access to care when you've got multiple children or multiple bus stops to get to your doctor. What else? Reimbursement and coverage gaps will probably get affected as well. And any program that was basically aimed at racial and socioeconomic gaps in healthcare could be completely lost, which is, of course, going to disproportionately affect our Black, Indigenous, and Latina women, and so people with any socioeconomic disadvantage disproportionately. So these are already the patients who have the worst statistics with complications in pregnancy and chronic disease. So that's all just going to get worse. Yeah, so that's all pretty morbid.
Yeah, I couldn't, everything she said plus, which is she plus in a much more negative way. When we think about midlife and beyond, think about Medicare and the potential for losing Medicare coverage. And so, we've talked about all the things that happen in younger women, contraception, prenatal care, but also for our older women, that's going to be a huge risk.
Yeah.
And to your point about telehealth, yes, every time, Congress kind of pushes it a couple of more months, I keep my fingers crossed that telehealth, I mean, it is crazy to think that they would crawl back telehealth, which has made such an impact to so many millions of people who haven't had access otherwise or wouldn't have access otherwise.
Yeah, especially like college students. I mean, that's who they use right now. And so I can't even imagine. What are some of the things in your very own practices that you cannot do now? What's changed there? Is it going to be a day-long list? Because that's how I think it looks.
I think it will depend on where you work in terms of the day-to-day changes. I'm very lucky to work in a somewhat liberal area in District of Columbia, but with the changes in telehealth, to talk about that again, I used to do a half day of telehealth a week, and that was a huge access to care benefit that we enjoyed. And we're seeing more and more insurance carriers not reimburse it. So now I have to tell more and more patients that that's not a option anymore for their follow-ups when we don't need to do an exam of any kind. And I only expect that to get worse. But we're already seeing some congressional action to get rid of the ability for DC to regulate itself, getting rid of our DC City Council and our mayor, so that it's called the Bowser Act, which is not, which is an intentional and somewhat cruel pun, but for Mayor Bowser. But that would basically give DC's judicial regulation up to Congress, which is Republican dominated, and we'd pretty much lose access probably to a lot of the benefits that we see in DC. So right now, luckily, telehealth is probably the biggest change I'm seeing, and just regular insurance shenanigans, but I could foresee that getting a lot worse.
Cheryl, you have anything to add?
It is so sad to hear that DC is struggling, because that usually is sort of one of the bastions of liberal access. Cleveland and Ohio, by the way, surprisingly, has been able to stave off some of the more draconian changes in terms of access to, prenatal care and termination. So some of the other states that have made things completely illegal, so far in Ohio, there has been some stopgaps, but it's not for lack of trying from very Republican Senate.
Well, both of you have sat the advocacy chair for the International Society for Women's Sexual Health, Studies of Women's Sexual Health. What can we do? I know people ask us all the time, is it a rally? Is it writing your Congress? What can we do to make our voices be heard more? What can we do?
Can I say the first and most important thing is vote? Vote. I think that has been a problem, that we have not gotten people out to vote. And that's not a big ask. And that's the small things, but that's what's going to count the most.
Mm-hmm.
And I think on the personal level, it is volunteering, it is joining a rally, it is writing your congressman, congresswoman, congressperson, it is joining advocacy groups. That's on a personal level. For the listeners out there who are not healthcare professionals but want to know what to do, I get that question all the time. There's a sense of powerlessness, and I think just for your own mental health, to actually do something and join something will help your mental health and give you a sense that you have some control over your own healthcare and life and liberty. And then the next step, I'm going to turn over to Anita, because that's why she has taken over the advocacy role, because she is amazing, and not only just because she's located in DC, but it is her passion, and I'm always impressed with all of her ideas.
No, that's very kind. Just to add on to your importance of voting, it's also knowing when to vote, because there's more than just a presidential election. And if you're not aware, when you register, or there's dozens of different organizations that'll tell you where all your local elections are, where you're supposed to vote. Those are equally important. Voting for your school board, like everything is important when it comes to voting. So there's more than just who's president. And if you don't know, just volunteer for your local election committee, and then you'll have a front row seat in both helping fair and free elections occur, as well as knowing when all the elections are. In terms of what you can do from an organization standpoint, first and foremost, I think all of us need to put more pressure on the leadership in our own organizations to say something. I would say that a lot of the OBGYN related organizations that I'm more privy to, I'm very proud of for standing up and publicly saying something with their platform. I think all medical institutions and all academic institutions should follow suit, because there is power in our alliance, and they're not going to do anything unless we put pressure on them to say that we, as their membership, want them to say something and stand up for what's right. Additionally, you don't just have to write your congressman or call them. You can show up at their office. You can make time that you can go and speak with a representative's council staff member directly. You can organize within your community to have a group of you go and speak with your local congressman, because sometimes that can be very powerful if you actually have the time to speak with them directly. And it feels, honestly, as someone who has lobbied at the local and national level, it feels a lot more it feels a lot like you have a lot more power when you get to actually walk into their office and tell them, as your constituent or as a representative of their constituents, what you're seeing and what you need them to take action on. I love everything I'm seeing about people showing up to town halls on a local election level, on a congressional election level. So we basically have to make an effort. I know the activation energy sometimes is really hard, especially when you feel completely helpless, but nothing is going to happen unless we put pressure on ourselves as well as our leadership to do or say something. And then if there is somebody that you find like really speaks to what is important to you, donating to their campaign is a very effective way to help that person get a bigger platform. And if you yourself feel passionate about it, think about running for a local election yourself. You don't need to have gone to law school and gotten a law degree or be in the political atmosphere to have a right to represent your constituency or your local area. So I highly encourage people, if they feel the call, to take a chance and run for a local election themselves.
Are you going to run this year, Anita?
I got a few other projects to think about first, but who knows? Maybe
Who
one day.
knows? Yeah, I can see it down the
Time I
road.
have.
There you go. How are organizations like IshWish reacting to everything that is happening? Are they able to help, or do they need help?
Yes and yes. I do think that they are taking action, which is why Anita is running the advocacy committee. The advocacy committee and the executive committee, so the president, et cetera, really have worked hard to speak out, both in letters and in trying to reach leaders in healthcare and in government to try and push things forward. But we absolutely need the help from women who can benefit from our organizations. We provide the clinical expertise and the research, and so we would love the input from our members, and also from women who are not necessarily healthcare professionals but want to support that. We actually have a patient-facing website, Procelia, and so women can go to that and they can benefit from it, but they can also contribute. And so, as Anita was talking about donation, you can also donate to organizations that you feel are helping both politically, but also just in terms of women's health.
We'll make sure we put that up on our website too. So thank you.
I feel like IshWish, like many organizations, is trying to figure out both how do I advocate for my membership and our patient population without also creating a target on our own back, because unfortunately those are the times that we're living in. What I'm seeing is that some of the person-to-person changes we're seeing are people who've lost maybe some research funding, figuring out how we can support people's projects to continue on. Those are some of the more like individualized advocacy initiatives that we have. When it comes to, speaking out on a more national level. I think we're still trying to figure out exactly how to be the most effective. And what I think would be the most beneficial is creating an alliance of all the different medical organizations, foundations that have a similar mission statement to what we have and speak to that truth, essentially. I think that's would be very powerful for our membership as well as our patient population. But I think right now we really need to first figure out who all our allies are and have the courage to come together and come out with the statements that not one individual institution feels like they're carrying the burden of speaking out. And, that way we'll have a collective strength.
I love that. Safety in
There's
numbers.
also, that is true. There's also a fine line between advocacy and lobbying. And so medical organizations that are nonprofits need to be very careful that they don't cross that line inadvertently.
Yeah.
And it looks like lobbying. And so, organizations like ISWISH and the Menopause Society really want to advocate for their patients, but as we think about, who do we reach out to, it's very careful that it doesn't cross that line into lobbying, and they are very careful about doing that.
I notice that menopause is a very hot topic right now, and I'm happy to see it. What are you seeing that's changing about menopause right now, and what progress do you feel has been made?
Well, I was amazed to see that Mary Claire Haver's book was number 5 on the New York Times bestseller list, which tells me that certainly, as we all know, menopause is having a moment, and that women are hungry to know about their own midlife women's health and how to get help. And so for that, I'm thrilled. And Oprah mentioned the Menopause Society on her special on menopause, and the website got 200,000 hits like in a day. So it is clear that women are hungry for this. And for that, I'm thrilled. And whatever is out there that's helping promote menopause and midlife women's health, that we're not in the closet anymore, that aging is not a dirty concept, and that to be proud of midlife women's health, and that there are things that are different for midlife than at any other stage is really important. We've just started a midlife women's health program at university hospitals. The incoming president of ISWISH, Sally McFedrin, has joined us to our hospital and our department to run this. So I think is going to be fantastic. The downside is that it is also very profitable. And unfortunately, in my opinion, there are many out there trying to make money off of menopause being a hot topic, and are not always following evidence-based medicine, and are luring women, because it is such an untapped need, to get help that may not be evidence-based, and to try things that are not necessarily evidence-based. So that's my caveat on that, is that I think that there are some bad actors out there.
Yeah, I agree.
Couldn't agree more with Dr. Kingsbury. I won't be repetitive, but again, it is so important that we are now having the conversation about all the nuances to menopause that we took for granted or didn't appreciate before, and that women are advocating for themselves. But the only way that we avoid these predatory kind of providers who want to sell snake oil or testosterone pellets or whatever it might be is that we have good quality research to back up evidence-based guidelines. And right now we can't keep relying on pharmaceutical companies to basically fund all of those studies, because they're only going to look at their bottom line, which is why government funded programs like the NIH and research programs or research studies that come out of it are so important, because we need to be able to provide evidence-based treatments for all of these conditions, or better studies to understand menopause and the perimenopausal period. So unfortunately, we're not going to be able to come up with the treatments or even get the good data unless we have good studies. unfortunately. So right now, that's something I am a little bit worried about with the defunding of so many
Yeah.
studies in general, the loss of the WHI trial, things of that nature. So I'm a little bit worried in the short term about what that's going to look like. But yeah, I'm really glad that women are speaking up for themselves.
That's so important. But I'm going to hold your feet a little bit to the fire right now. So, what are these uh, black box labels, and how does hormone replacement therapy show up in your practice?
I'll let Dr. Kingsberg speak on that since I know she's met with the FDA and the big players with box warning.
Well, boxed warnings really are the FDA's whole purpose is to protect, our healthcare. But sometimes it gets in the way of good healthcare. So, for example, the box warning for estrogen is a problem because it is a class label, meaning that everything with estrogen in it as a pharmaceutical option has the same box warning. So vaginal estrogens or local estrogens that are meant to be inserted into the vagina for a local effect to address what we call genitourinary syndrome of menopause, or the changes in the vagina and urogenital tract that happens at menopause due to lack of estrogen, now carries the same warnings that systemic estrogen has, which clearly is not the same. Yet women go in, they pick up the prescription that Dr. Mickey has given them for their vaginal estrogen or their vaginal DHEA, and what they see on that vaginal estrogen is risk of breast cancer, risk of stroke, risk of dementia for vaginal estrogen. And so women are like, well, I'm not taking this. And,
Yeah.
this is crazy. So the box warning is a problem. And it scares women away from much needed treatments. And even systemic estrogens no longer, from what we know from the research, carries those same risks and dangers that we used to think, from the early research results from the Women's Health Initiative from early 2000s. And we know that that's changed. And the Menopause Society is working very hard to educate clinicians as well as women about how to properly use hormone therapy, because it really is a useful first-line treatment for women who are suffering from vasomotor symptoms. It's not for everybody, but it certainly can be for a lot more women that have been using it in the last 20 years.
And unfortunately, the things that I'll add to that is because unfortunately medicine can be somewhat litigious. In addition to patients being scared of taking the medication, there are providers out there that are scared to prescribe it based off of data that does not apply to, for example, vaginal estrogen. So it's a huge problem. And it's not like even at the best of times, there was somebody who was sitting at the FDA who was making sure that every medication had the appropriate labeling and the right evidence to back it up. It is very hard to get a seat at that table to even get the audience of the FDA to explain that the very good data out there on vaginal estrogen proves its safety. So there's a lot of problems with how the system works, and it's hard to be a player in changing that system. So going back to the question of what you can do for advocacy, if people know, people in their own family or friends who work in these like big player institutions, like helping to educate or at least get the right person a seat at that table is a way of advocacy as well.
So these black box labels is this studies that were done years ago, and these pharmaceutical companies are not removing this? Uh, yes.
Right. Well, that's part of it. It is financially not beneficial to them, especially since so many are now generic products, that it doesn't serve them financially to push for that. And also, it's just very hard to get these box warnings removed once they're there. It's very hard to sort of prove the negative. And so it just remains. And from the FDA's perspective on vaginal estrogens, the issue was, as there was a hearing to try to change that, their position was that low amounts of estrogen is not necessarily the same as vaginal estrogen. So how low is low? And so because there couldn't be a specific amount, there was no change.
Sounds lovely. How are innovative treatments like hormone replacement for women going to be impacted by federal funding?
There's a
Or the
couple.
lack of federal.
Yeah, I was going to say there's a couple ways we can see that from the research perspective. If we don't have good data, we're not going to better understand menopause. We're not going to come up with new treatments for people who have contraindications to the very safe treatments we had. From a payment perspective, loss in insurance coverage, we already struggle with new drugs that come out that are great being unaffordable for most patients. And some of our generics are luckily very affordable, but if people don't have insurance, maybe that's even still not going to be affordable. We'll see. Yeah, those are some of the things that just come to the top of my head in terms of what we might see. I don't know if Cheryl.
Those were all, I couldn't agree more. And I want to double emphasize the lack of research, that we can't have innovation if there isn't research. And the funding cuts in NIH research and the limits put on what kind of research you can do and what you can say in a grant proposal, including not being able to use the word woman, is really going to tie the hands of anybody trying to do innovative research in women's health.
I mean, even right now, the WHI data that was the largest study on women that started in the late 90s, early 2000s, that data is still being mined today. And we continue to see new findings on aging, cognitive decline, cancer risk, chronic conditions. It's one of the largest, most comprehensive longitudinal data sets that we have on women in the world. And we just saw cuts to the WHI, which is not only treating women as second-class research subjects, but we already have this great data set and this progress being made. What is the utility in cutting it? So yeah, we're gonna see a lot of changes.
So let me ask this question. At this moment, how can we better use the research that we do have in making progress? Because it's my understanding we do have research that's there, but a lot of the medical schools are not even using that research. Am I right or am I wrong?
You're
Well,
correct.
yeah, you're hardly ever wrong, Patty.
I am wrong, but it angers me to know that some research is there for them. And here some of these medical schools are using the same curriculum. Is it because they're lazy? I don't know. You don't have to answer that. That's just my
Well,
feeling.
we're actually doing some studies that mirror some of work that's been done by medical students in Chicago to expose just what we're actually teaching in medical school. I'm speaking specifically about sexual health and and eventually, hopefully, we'll extend this to gender care as well. But at the end of the day, a lot of these medical institutions, medical schools, um, subspecialty institutions like OBGYNs, urology, psychology, what have you, they want data to back up any recommendation that you make. So the first step is basically someone has to be the advocate for this change. Someone has to care enough to take on the extra unpaid work of researching what all the medical schools are doing right now, coming up with a thesis for it, getting it published, then taking it to all of these different big players and showing that there is a need and that there's something to address that we need to address, then coming up with the proposed changes. And then someone has to follow through and see that that's a lot of work. And so that's really what it takes, is somebody to care that much and get a group of people together. That's what we're trying to do with some medical students I'm working with in DC, is to get those changes implemented in DC. But it takes a lot of effort and activation energy to get that done. And talking about doing that nationwide, we just need more leadership. We need more influence. We need people empowered to elevate the people who know what they're talking about. We need a seat at all those tables if we want to see any of those changes happen, because why would anybody change the status quo? That requires work.
I also think there needs to be a champion in each medical school for those topics. So
Yes.
at Case Western Reserve, we do have sexual medicine experts, but not every medical school does. And so they're uncomfortable teaching something they don't necessarily have the expertise to teach. But ISWISH is actually sponsoring some research in finding out what's happening in clinical training in sexual medicine in medical schools, in midwife programs, in nurse practitioner programs. So not just, and PA programs, not just medical school. And then you have to think beyond medical school into residency. We know that barely 20% of OBGYN residencies are getting menopause training. So we know that it goes beyond even medical schools. So, and there's so much more content as we learn more, as medicine does expand, the amount that can be taught, that can be in a lecture, that can be, in a chapter, grows. And so somebody is sort of making the decision of what's the priority. And sexual health often is not. It should be, but it often is not.
And
When
just
you're
to add,
passionate, go
oh,
ahead.
sorry, just to add to that, sorry, a plug for an excellent example of that kind of advocacy is the grassroots organization Tight-Lipped, where it is patients themselves who were so frustrated with the process of getting gaslit by the medical system about their pelvic pain, created a grassroots organization to advocate for awareness and understanding. They created their own podcast to help elevate patient stories about pelvic pain. And now they are at the forefront of connecting OBGYNs around the country to help understand where the learning gap is. How do we not only help fill that need at different institutions and residency programs, but they themselves are using their influence to get a seat at the table for those who come up at, for example, APCO-CREOG, which is our educational national governing bodies, to demand that every program implements some kind of training for OB/GYN residents from a national level, and change those guidelines for you can't graduate without learning this stuff. So that's an example in the pelvic pain arena of advocacy. But again, somebody cared enough to create an organization and make this their like calling. And we just need to see more of that.
I love that. Thank you for sharing that. So I always ask this at the end of the podcast. Is there anything that I missed? Is there anything that you want to add? Because you bring so much to the table, and there's so many people out here that are listening and that will listen way down the road, years to come. Is there anything that I missed here today that you want to talk about?
Well, Patty, the one obvious thing is that you forgot about She Plus, to put a plug in for She Plus. There's a reason why we're on your board. We happen to think it does an amazing job in bringing research funds to women's health, to sexual health. I mean, it's amazing. And we're not relying on government funds for She Plus. And so please put a plug in for you, and for your foundation, because it does an amazing job. And so your listeners can support that. They can donate, and they can appreciate all that you have done. Not just this podcast, not just the time you volunteer, but the foundation has done an amazing job.
Thank you. Thank you. It's so important, like for the podcast, for people who are able to, they're looking something up. And so therefore they find out a little bit more about what we do and how we do it. So, but thank you so much, because to bring this information out to people is so important to me and to everybody at the She Plus Foundation. And I'm so proud that we have such amazing doctors such as yourself, that bring so much information to women out there that want to know more. How can they stand up, know more about their body? So thank you so much for everything that you do. Right now, I want to thank Dr. Kingsberg and Dr. Mickey. Thank you for joining us today. If you want to learn more about Both of them go to the She Plus Foundation website. If you like what you heard today, please rate and subscribe to our podcast. For more information on the She Plus Foundation, go to www.sheplusfoundation.com. Remember, sex care is self-care, and sexual health matters. Thank you.